All right, so welcome everyone. It is so great to be here with you all. I'm delighted to have Ronli Levi join us for this installment of the guest speaker series. So before I introduce Ronli a little bit, I wanted to just go over some general housekeeping for the talk and give a brief intro to CFS in this series. So yeah, as Climate Farm School is continuing to host courses throughout the US and Europe, we're also taking the time to explore the critical nexus between agricultural health, planetary health, and human health. So this guest speaker series was really born out of this desire to integrate the healthcare world, into the work we're doing at CFS, sorry, and give our community the opportunity to really engage with important topics such as health. So yeah, I think Runley is an amazing example of someone who's doing this work with food and nutrition, and I'm really excited to introduce her today. So Ronli Levi is the Director of Research and Evaluation for UCSF's Seligman Research Team. In this role, she manages research evaluation, and community-based interventions aimed at reducing food insecurity and improving health. And additionally, Ronli supports the evaluation efforts for Vouchers for Veggies-EatSF, a produce prescription program started in San Francisco in 2015. As part of the GusNIP in Nutrition Incentive Hub, Ronli serves as the PPR advisor, providing training and technical assistance to her produce prescription implementers. So I know that I'm excited to hear from her, and I wanted to remind people that this is a collaborative space, and there will be about 10 minutes at the end for questions. So we would love to hear from you, and if you have any questions during the presentation, don't hesitate to put them in the chat. So without further ado, I will pass it over to Ronli to discuss food as medicine and produce prescription programs. Thank you so much for being with us today.
Thanks so much for having me. I'm going to go ahead and share my screen and just let me know if you're seeing everything okay. Are you all seeing the regular view? Okay, perfect. Well, thanks everyone. Really appreciate you having me today. And like Claire said, feel free to put any questions you might have in the chat, and hopefully we'll have some good time at the end to answer any of those questions. So today I'm going to be talking about providing an overview and discussing considerations for implementing food as medicine programs. Oops, sorry about that. If I can get to the next slide. And I have no conflicts of interest to disclose. So I just want to start out by framing where things stand in terms of dietary intake and chronic disease in this country. The US ranks last on many key health measures compared with other high-income nations, including access to care, the care process, and health outcomes, despite spending more as a percentage of its GDP compared to other high-income nations. And people in the US generally have poor dietary quality, with many not meeting recommended fruit and vegetable intakes and whole grain targets, but exceeding recommended sodium intakes, among other things. And 45% of cardiometabolic deaths are due to poor diet. But the majority of Americans say they'd like to eat healthier, but that the number one barrier is the cost of food. And many Americans experience food insecurity, which means having limited or uncertain access to enough food. And this is one of the USDA definitions. On the other hand, food security exists when there is access by all people at all times to enough food for an active, healthy life. And food insecurity remains a challenge in the US. This is the most recent numbers. These come out annually, so the 2024 numbers will come out in September or early October. In 2023, 13.5% of households, representing about 18 million families, experienced food insecurity. And within this, you can see that about 5.1% of households face the most severe form of food insecurity, also known as very low food security, where food intake was either reduced or meals were skipped due to limited resources. And this reflects a notable increase from 2022 when the overall food insecurity rate was 12.8%. And in this graph, you can see that the prevalence of food insecurity overall and the most severe form of food insecurity has ticked up since 2021. So food insecurity increased from 10.2% in 2021 to 12.8% in 2022, resulting in 10.3 million more people, including 4.1 million more children who live in households that experience food insecurity. And there was a lot of discussion during the pandemic about rising rates of food insecurity, but you can actually see from the official numbers here that food insecurity rates remained relatively stable in 2020 and 2021, which actually reflects the strength of all the policies and programs that were rapidly put into place during that time. And now the increase of food insecurity rates are really thought to be a reflection of the phasing out of that pandemic relief coupled with the rising cost of food. I also want to highlight another term that's been gaining a lot of momentum recently, you might have heard, called nutrition security. And although there's really not one agreed upon definition or way to measure this, the USDA has defined it as the consistent access to nutritious foods that promote optimal health and well-being for all Americans throughout all stages of life. And nutrition security doesn't replace food security, but rather builds upon it and puts a renewed emphasis on diet quality and equity. And while food security has long been understood as having enough access to nutritious foods, the construct of nutrition security elevates the importance of having high quality foods that support health. And just to tie all this together, food as medicine programs bring together these two concepts as they are generally intended to simultaneously support food insecurity and improve diet quality. But before we move into discussing how food as medicine programs may support food insecurity and diet, I want to talk a little bit about how people experiencing food insecurity often use various coping strategies to manage limited access to food. So that might include choosing lower cost, energy dense foods, skipping or reducing meal sizes, limiting the variety of foods they're eating or overeating when food is available, or even consuming expired or spoiled foods to avoid waste. And while these strategies can help stretch resources in the short term, they can contribute to higher risk of obesity, diabetes, and other diet-related chronic diseases in the longer term, and can also make it more difficult to manage an existing chronic disease. And this brings us to the broader connection between food insecurity and health. And there's been a significant body of research that has shown that food insecurity and poor health have a bidirectional relationship. So limited access to nutritious foods can contribute to the development of worsening diet-related illness, such as diabetes or hypertension. And at the same time, poor health can increase financial strain due to higher healthcare costs, forcing individuals to make trade-offs between food, medications, and other essential expenses. And as illness progresses, challenges like having to miss work due to illness can further reduce income, making it even harder to afford food and increase the risk of food insecurity. And this cycle really highlights the deep connection between food access and overall well-being. And so just to put this all into context, adults in households with lower food security are significantly more likely to have a chronic illness. And in fact, those experiencing very low food security, again, that's the most severe form of food security, have a 53% probability of developing at least one chronic condition. And this pattern isn't limited to adults. Young adults facing food insecurity are also more likely to have chronic conditions compared to their food secure peers. Adults in food insecure households are about 50% more likely to visit an emergency room and be admitted to the hospital, and they may stay hospitalized about 50% longer than adults in food secure households. And one of the most well-documented connections between food insecurity and poor health is with diabetes. And this graph shows that people living in food insecure households had more than twice the risk of developing diabetes, even after accounting for differences in age, gender, race, physical activity, smoking, alcohol, and diet quality. And you can see that stark difference in incidence of developing diabetes between those that are food insecure versus food secure. And food insecurity doesn't just contribute to poor health, it can also exacerbate existing health conditions like we talked about and make managing health even more difficult. So food insecurity is often cyclical, with individuals facing episodes of food shortage followed by periods of adequate food availability. During times of food shortage, individuals may resort to strategies that I mentioned before, like skipping meals or reducing intake to stretch their limited resources. And conversely, when food is more available, may be more likely to overeat or binge. So for individuals with diabetes, as an example, this pattern of alternating food scarcity and abundance can disrupt blood sugar levels, leading to poor glycemic control. And this increases the risk of both hyperglycemia, so high blood sugar during periods of food adequacy, and hypoglycemia, or low blood sugar, during periods of food shortage. Both can lead to serious complications. And studies have shown that the exhaustion of food budgets at the end of the month puts individuals at greater risk for hypoglycemia, because while you might be taking the same amount of medications, if your consumption decreases, that would put you at risk for lower blood sugar. And this study shows that the risk of an inpatient admission for hypoglycemia increases 27% during the last week of the month, when budgets are most likely to be exhausted, compared with the first week of the month in the lowest income zip codes in California, a pattern which was not seen in higher income zip codes. And these results have been demonstrated by other studies in the literature. Households experiencing food insecurity are also more likely to report multiple episodes of hypoglycemia or low blood sugar and are more likely to attribute these episodes to the inability to afford food. Consequently, food insecurity is also associated with increased health expenditures, with this study showing that food insecure households spend about 44% more a year in healthcare expenses, or about $1,800. And this increase in expenditures is most pronounced for people with chronic conditions. The odds of becoming a high-cost healthcare user in the future are 46% greater for food insecure people as compared to those that are food secure. And this difference in expenditures, that $1,800, represents approximately $77.5 billion in additional healthcare costs compared with what would be expected for individuals without food insecurity. So big implications for healthcare expenditures. And from a cost standpoint, you can see there's a significant cost differential between the monthly cost of food versus one emergency room visit for low blood sugar. So now that we've sort of set the stage and discussed the connection between food and nutrition security and health, what are some ways we might address these connections? Well, given this link, healthcare organizations are increasingly looking at upstream ways to address patients' health-related social needs. And so examples of health-related social needs include housing, transportation, utilities, family, social support, education, employment, and what we're all here to discuss today, food. So one way that health systems and insurers are addressing health-related social needs is through food as medicine programs. And there's no one agreed upon definition for food as medicine or FIM programs, but typically they represent the spectrum of food-based interventions integrated into healthcare. And the target population for these interventions are usually those with or at high risk for certain health conditions. These are usually diet-related, like diabetes or congestive heart failure, hypertension, cancer. And it also often prioritizes people with or at high risk of food insecurity due to that connection between food security and health. And in the clinical setting, the way this might work at a high level would be a patient is screened for food insecurity or other eligible condition. They're then referred to a food as medicine intervention or program and enrolled in that program, which would then in the short term would lead to improvements in diet quality, food security, and clinical satisfaction, and in the long term lead to improvements in health outcomes and utilization. So when we talk about food as medicine programs, we're usually talking about the upper third of this pyramid. So produce prescriptions, medically tailored food packages, also sometimes called medically tailored groceries, and medically tailored meal programs. And these interventions range in intensity and implementation. So as you go up the pyramid, these interventions move from a focus on prevention to more of a focus on treatment. And what's not pictured here is that as you move up the pyramid, implementation costs also typically increase, and the complexity of patient needs or sort of the acuity of their disease or illness also increases. And across all of these interventions, the program dose, so the amount of the benefit, number of meals or pounds of food provided often varies, as does the duration or length of the intervention. The population served can also vary pretty significantly, and most FIM programs are also often coupled with nutrition education and counseling. Oops. Okay. And food as medicine programs can often be divided into two categories. So programs that operate on-site at the health system, so-called on-site programs for these purposes, and programs that are typically operated by a community partner. So these, of course, can vary, as does everything, but programs often operated on-site at the health system are food pantries or mobile food distribution trucks, which are co-located at a clinic. Clinics might also offer SNAP enrollment assistance on-site, but clinics might also refer patients out to community programs that provide medically tailored meals or groceries, produce prescriptions, or they might be referred out to a food pantry in the community. Federal nutrition assistance programs are typically not considered food as medicine programs, with the exception of WIC, which is the nation's largest federal produce prescription program and provides women and children with additional benefits to purchase fruits and vegetables on top of their regular food package benefit. And there's strong evidence for WIC around its impact on diet quality, food security, and maternal and birth outcomes. And although it's designed for a specific target population, WIC is the only federal nutrition assistance program established with the sole purpose of addressing health rather than the dual purpose of supporting American agriculture and public health like SNAP. And so while WIC is designed as a short-term intervention, its goal to influence nutrition across the lifespan offers an important example of how we can successfully scale these types of interventions. Okay. So to give a bit of a deeper dive into how these programs work, medically tailored meals are fully prepared meals designed by a registered dietitian nutritionist to meet the specific dietary needs of a patient. These meals are usually delivered to a patient's home and meet around 50 to 100% of their nutritional needs. And medically tailored meals are usually reserved for sort of the sickest population. So people who are maybe recently discharged from the hospital, or have limited ability to cook or prepare their meals. So they're usually living with one or more kind of complex health conditions. Medically tailored groceries are a selection of healthy groceries, which can contain items like lean proteins, fruit and vegetables, and grains, though the components can vary and amounts can vary pretty considerably. Patients really need to be able to cook and prepare groceries, and often participants pick these groceries up at either a CBO, a community-based organization, or at the healthcare site, but they can also be delivered. And if you remember that pyramid, this is sort of the next tier after the medically tailored meals. So these patients are a little bit less sick. Again, they can perform sort of those activities of daily living. It's a little bit more focused on prevention than treatment. And then as you move down the pyramid, one more tier, produce prescriptions are usually paper vouchers or debit cards that can be used to purchase fruits and vegetables at participating grocery stores, corner stores, or farmers market. And increasingly, they're also being distributed in the form of either a produce or a CSA box. And these can either be picked up at a CBO as well, or clinic, or delivered to the participant's home. And evidence supports positive effects of food as medicine interventions on food insecurity, diet quality, health outcomes, and healthcare utilization and costs. We probably have the most amount of evidence on medically tailored meals and the sort of most robust evidence. And this is usually because we're conducting these studies in sort of the sickest patients. And so you're more likely to see greater improvements in outcomes. But there's really a lot of growing evidence for produce prescriptions in particular, as well as medically tailored groceries. So there's a growing number of studies, and we're seeing some strong improvements in outcomes on for health for produce prescriptions. There have also been a few computer modeling studies that are designed to predict the potential impact of food as medicine interventions. And so this modeling study, which was done by Tufts about a year or two ago, shows the potential impact of produce prescriptions. And it found that if you implemented produce prescriptions in 6.5 million US adults with both diabetes and food insecurity, you would prevent 292,000 cardiovascular disease events and save $39.6 billion in healthcare costs and $4.8 billion in productivity costs over a lifetime. And it showed that produce prescriptions can be a cost-effective solution. However, like with anything, evaluation challenges do exist, as most studies are quasi-experimental or pre-post interventions. Many have small sample sizes, are single-site programs with a very specific population, or have low retention rates. And there's also a lot of variation in program design. So the amount of people are getting, the length that people are getting it for, how they're receiving the intervention. So it can make it really difficult to draw conclusions. Most studies also have no control or comparison group, and you really need a lot of data to show impact, and not a lot of studies have that. And most programs have limited funds available for evaluation. So those are some of the limitations when it comes to evaluating these programs. I do want to kind of take a sidebar and provide an example of one food as medicine program in action. So Vouchers for Veggies is a program that our team started in 2015. Dr. Hilary Seligman started it at Zuckerberg San Francisco General Hospital, which is the county hospital here in San Francisco, based out of the University of California, San Francisco. And the aim is to increase access and affordability of healthy foods for households with low incomes by providing vouchers for fruits and vegetables. And it works by participants enrolling through partnering clinics and community-based organizations or other supportive services like housing sites. Participants receive $40 to $110 per month for around 6 to 12 months in fruit and vegetable benefits that can be redeemed at any of our partnering vendor sites. So groceries, corner stores, farmers markets throughout San Francisco. And this is an example of our voucher, as well as the electronic debit card that we use. And so some of this I've already said, but we partner with different community distribution sites across San Francisco, which include clinics, supportive housing sites, senior centers, family resource centers, as well as all of the WIC clinics in San Francisco. We also have 40+ vendor locations, which include farmers markets, grocery stores, and corner stores in the neighborhoods where people live. Participants receive $40 to $110 per month for 6+ months, where they can then redeem those vouchers at these participating vendor locations. People either receive paper vouchers or produce cards, and we're currently testing ways to scale dose by household size, so the amount that people receive by household size. And the participants that we serve really vary. We really try to partner with individual community-based organizations to serve the people that they need. So they really help to dictate who is eligible. So that includes people who are food insecure and low income. They might have a chronic disease diagnosis. We also serve a lot of older adults, families with children, and then all pregnant people in San Francisco. And program locations include San Francisco, that's our home base, as well as other California counties, including Los Angeles, San Joaquin County, which is in the Central Valley, as well as some other locations across the US, both urban and rural. And so since 2015, we've served over 25,000 households, and we've seen significant improvements in fruit and vegetable intake, so by over 1 daily serving per day. As well as significant improvements in food security. This number is low at this moment, so it's grown a lot since we last reported it, but we've infused over $2 million in fruit and vegetable purchases in underserved neighborhoods and have consistent partner, participant, and vendor satisfaction. And as I mentioned before, we are operating in a number of places across the US and have been able to see consistent outcomes across those various geographic regions and populations, including both urban and rural areas. So this is just one example of a produce prescription program in action. There are many others that are operating across the nation, and they're all operating in different ways. So depending on the community that they are serving, they might be operating a voucher model like we do, but that's not necessarily the only model or the best model. There's lots of programs that are working with local farmers to distribute CSA boxes and have an emphasis on local sourcing. So there's really different programs that are serving different needs based on the goals of their program and the needs of their community. So I want to kind of, this final section, talk a little bit about current considerations for FIM program implementation. So there are a few questions that arise as we're thinking about how to design and implement these programs. So the first consideration is, are we focusing on people with high disease burden, so those that are kind of the most sick, or are we focused on prevention? And there's been a big momentum towards focusing on people with a high disease burden, like congestive heart failure, because we can prove a return on investment in a short time frame. And this aligns with the needs of people who are beholden to an annual healthcare budget, as an example. So if the money goes out this year, it better pay off this year. That's what some people might want to see. On the other hand, if we move further upstream, like before people develop obesity or cardiovascular disease or any other kind of chronic illness, maybe even all the way to the pediatric setting, many more people would be eligible for services. We may be able to prevent the onset of diet-related diseases completely, and we may have population level improvements in health outcomes. Obviously, in the long term, this offers a much greater potential for return on investment, but we would have to wait for it, and we might have to wait a long time. The next consideration is dose and duration. And this is currently one of the most unanswered questions in the field of food as medicine. So, how much people get and for how long. And so, particularly when it comes to produce prescriptions and medically tailored groceries, do we serve more people with a lower dose or less people with a higher dose or longer duration? So, if you're thinking about it for approximately the same amount of money, you can think of your options are to reach fewer people with more services or more people with fewer services, and there are trade-offs to both. So, advantages of a high dose, so more services, low reach system is though, although a smaller number of people benefit, you're more likely to have a demonstrable impact on health outcomes. And a high dose intervention may be required in order to change habits so that after the program is withdrawn, you can see that effect maintained. On the other hand, advantages of a low dose, high reach system, we reach more people and fewer people are left out, and you may be able to provide services to entire households rather than individuals. So there's really not one right solution. It's really just thinking about the trade-offs. Sourcing is another place where there's some trade-offs that folks might have to make and a lot of considerations. So where is the program getting the food from? Are implementers working with large national retailers or small local source and producers? So the first thing to consider when building a retail network is identifying where do participants currently shop for food? And do the retailers that programs are building partnerships with align with their participants' cultural and personal preferences? Large retail networks can be important partners, especially when it comes to scaling and reaching participants in wide geographic regions. On the other hand, many programs also prioritize local sourcing, which can be an important way to support local agriculture and can improve community health. Another consideration is how participants receive the food. Does the program offer home delivery for those with mobility issues or transportation barriers, or do participants need to pick up their food? If it's a pickup model, are the locations easily accessible and close to where participants live? And proximity and accessibility are important factors for ensuring patients are able to remain engaged with the program. Finally, are participants able to select their own food, or are the packages pre-selected? Choice can offer participants more dignity and allow them to choose culturally relevant options. On the other hand, pre-selected food items offer some operational efficiencies and may allow programs to more easily prioritize locally sourced items and can also introduce participants to new foods they might not have chosen themselves. So there's a lot of trade-offs to consider, and it's important to be transparent about these trade-offs and acknowledge the constraints under which different stakeholders are making decisions. But at the same time, we really have to prioritize the needs of participants, or we'll end up creating a system that people don't want to use or that they can't easily use, and that could widen disparities. So now is really the time for us to be thinking about these trade-offs intentionally so that we can think about the best way to influence policy and create a system that works for the people we're serving. And with that, I will open it up to questions. Thank you.
Thank you so much. That was such an amazing presentation, and it's so exciting to see all the research that's being done. And yeah, just how much information there is and to see all the work that you're doing. So yeah, I know I have a few questions, but if anybody else does, please take the floor. We have one in the chat from Nitesh. Has there been any studies on how regenerative agriculture produce has created an impact on produce?
And Nitesh, on produce in general, or maybe you could clarify the question.
Hi, Ronli. Thanks.
Hi.
Thanks for the presentation.
Yeah.
Yeah, there are a lot of programs out there that are starting to focus more on regenerative agriculture, and there have been some impact studies around the importance of regenerative agriculture and how some of these programs or the output of these agricultural programs are being seen as food as medicine projects and programs. So, just wanted to get your take in terms of, are you seeing some of these projects? Are you seeing some of these programs? Are sort of farmers collaborating, with institutions to say, hey, this is a different focus that we have, that we're focusing on the nutrition in soil. And as a result of the nutrition in soil, there is a higher attribution on the produce that is coming off a particular piece of land. So just wanted to get your take. if you've seen any of that. Thank you.
Yeah, it's a great question. And I will just preface this by saying that I am not an expert in regenerative agriculture. So I'm not as familiar or up to date with the studies, but I will say there are programs that are operating. Some near me. I'm based in Oakland. There's a program out of Alameda County called Recipe for Health that is really focused on regenerative soil and regenerative agriculture and locally sources produce boxes as part of their food as medicine program. And there's also some work that's being done to make sure that policies that allow for Medicaid to pay for these types of programs also include a local sourcing component as well. So that's not true in all states. Not all states have these waivers that allow for Medicaid reimbursement for these programs. But there are more states that are having them. California is one of them. Hawaii is another. There's a few that are in progress, and I'm happy to share a link for which states have those waivers. And each waiver is different, but there is advocacy in certain states to support local sourcing. And so there's quite a variation in terms of how these programs are modeled and functioned, but there are a number of programs that are really focused on promoting local agriculture, supporting BIPOC farmers, and supporting local economies in that way. And the GusNIP Nutrition Incentive Program, which is a program of the USDA and supports produce prescription programs across the country, is one example that's supporting different models, including a lot of these models that you've just mentioned in the chat.
Cool. Thanks very much for that.
Yeah.
I had a quick question.
Yeah.
I don't know, is there any studies or work being done with like sharing gardens where you know the community creates the garden and then the garden is used for people with lower food security? Were you able to hear me?
Sorry, you cut out a little bit, but I think I heard you say anything about sharing gardens.
Yeah.
Yeah, so a good question. There's in terms of the food as medicine space, there are some groups that are using gardens, on the healthcare system campus and using that to support their produce boxes. There's also one example in Hawaii where there's a garden that's part of their healthcare system, and people can go up there if you're part of the clinic, and then they also use that produce for their produce boxes. I don't know if there's any examples. I think one of the challenges there is being able to produce enough to support a full produce prescription program because you're often having to provide boxes pretty frequently, usually bi-weekly. So being able to support that. And usually these boxes are pre-selected. So I don't know any examples where people are able to choose within the garden, but it's a great approach.
Yeah, I was thinking more of a supplement thing just because
Yeah.
the beneficial that of gardening itself and getting your hands in the soil and
Absolutely.
just, helping serve others kind of increases health.
There's lots of programs too that offer, nutrition education as part of their programming, including, sort of the
Right.
learning how to garden. I think it just
Yeah.
also depends on the goals of the program
Right.
as well.
Okay. Cool. All right. Thank you.
Oh, I think you might be muted.
Yes, thank you. Yes, hi, I'm Kadeen. This talk was fascinating. Thank you for all of your slides. My question is, I missed the first couple of slides, so maybe you answered them. But demographically speaking, who is food insecure? Or where are people? And then adjacent to that, like what are the drivers of food insecurity? Is it really just income or systemic inequality? I'm just thinking about that, like the origin story. Why is this happening?
Yeah, great question. And I was just looking through my slides. I don't have a slide on the demographics, but that is something that is well studied, and there's lots of people that are missing, missing from our work too because of the way that demographics are captured. So households with children are often food insecure, single-headed households, people of color. So we often see that those that are Latino or Hispanic or Black African American are food insecure. So there's some disparities by race, ethnicity, as well as those households that are headed by single mothers. And then, of course, income is one of the big drivers. And yes, what you said, this is much more system. It's not just income. So there's access to food, there's education, there's unemployment, there's systemic factors and policies that have created and driven food insecurity in this country.
Thank you. So, quick follow-up
Mm-hmm.
related to that. If people's income increased, or do people with higher incomes, like if there was a control, are people making better choices when they do have more income?
Well, I think it's just because I think one of the things that is sort of a misnomer or a myth is that people who are low income eat badly. We all eat badly. You know, there are, of course, reasons why it is harder to afford healthy food when you're low income. But in general, if you're looking at our dietary intake in the US, it's poor. And it's not that much more poor if you're higher income versus low income.
That's interesting. Okay, yeah, that's what I wanted to figure out.
And I'll share in the chat as well some of the USDA has some statistics and graphics for food insecurity that might be of interest to you.
Thank you. I'll keep going. What should we be doing at a population level to improve food, like nutrition intake population wide?
Great question, a big question. Well, I think we need to be investing in policies that support health. So making sure that we're not making cuts to SNAP. We're investing in programs like SNAP that are known to support food security, and there's strong evidence that they also support health. In general, we need to be, I think it's important that we're focusing on sorry, there's lots of ways to answer this question.
Yeah. Well, is it that consumers need to make better choices, or the market needs to have better choices that we can then consume, enjoy? Both.
Yeah, great question. I don't think we can put this all on individual. I mean, there's lots of systemic factors that influence our food choices that are unrelated to individual habits. And it's about accessibility to healthy foods. It's about food prices. It's also about, there's places where it's not safe to walk. Or, food deserts I feel like was a big kind of a buzzword a few years ago. Maybe it still is. But there are places that are just flooded by, fast food chains, and there really isn't a grocery store in sight. And there's also, as food prices rise, it becomes really difficult to afford the healthy foods that you need. So yes, maybe there are some things around individual food choices, but in general, I think this is a larger systemic issue around the policies that are in place.
Thank you.
Yeah, to support our food environment.
I had a question for you. I was really I thought the way that you kind of described the cycle between shortage and adequacy that fluctuates kind of even just throughout the month was really poignant. And I'm curious to hear a little bit more about what are the next steps for people after the program is over, because it sounds like there's quite a bit that is building these healthy habits and maybe giving them the resources to, explore access in their area. But I think consistency being such a big part of the equation, what does that look like after the program has completed for people?
Yeah, this is a big one because these programs in general are by design short term in duration. And it's a question of what is the appropriate length? You know, obviously there are things like limited funds to consider. A lot of these programs are funded by short-term grants. You also, and sort of when we were talking about those trade-offs, we were talking about like, do you serve people for a small number of people for a long time or a lot of people for a short period of time? And there's really sort of like no, one way to think about it or one right answer to that question. But eventually, these programs do end and aren't intended to go on forever, whether that's good or bad. And so we really need to be thinking about making sure that we're not causing more harm when people sort of by creating sort of a cliff for people, right? Where they're getting these additional benefits and then they fall off. And so being able to have wraparound services where people are connected to additional resources. So making sure they're enrolled in SNAP, making sure they're enrolled in WIC if they're eligible, making sure that they're, have access to pantries or other support services that might help sort of ease that gap. And then from a sort of a behavior standpoint, making sure they have access to, the appropriate nutrition education and things like that. So they, folks know sort of how to maintain some of the habits they might have learned while they were on these programs. Some of these programs, I think, are not necessarily intended to support food security. So, for example, medically tailored meals, you don't have to necessarily be food insecure to be on that program. It's really designed to support those that are, have the most sort of acute or complex chronic diseases and may not be able to, sort of make or prepare meals for themselves. And so maybe food security is not an issue, but there are a lot of people that food security is an issue, especially as they're sort of moving down the pyramid and you're thinking about produce prescriptions and medically tailored groceries rather. And so making sure that you're offering sort of adequate support as people roll off these programs, I think is really important. And then additionally, there are programs or there's sort of increasingly people are thinking about like, how do you step down from one program to another? So for example, maybe you're getting a medically tailored grocery and now can you then be transitioned to a produce prescription program? Or you're maybe getting a medically tailored meal after you're discharged from the hospital, you're doing a lot better. Could you be transitioned to a medically tailored grocery or a produce prescription to sort of support you in your transition from sort of a more complex chronic disease to as you're getting, as you're improving in care. So that's sort of one way to think about it. There's also because you're generally getting these programs as part of your care in the healthcare system, there's usually sort of a coordination of efforts to make sure that you're, hooked up to the resources you need. And that's a really important aspect too, that these things aren't just happening in a vacuum. Like we're solving a food issue, but there's, of course, making sure that people have the other resources they need, housing, employment, et cetera, to meet their needs.
Thank
So it's a
you.
little bit of a long answer.
No, I get it. Yeah, it seems like a very complex but important program to implement. So I appreciate you sharing.
I have a kind of question topic. I don't know, question or topic relevant to this. And forgive me, but I'm just sort of thinking aloud right now. But it just seems like as you're gathering all these studies and support that, positive support that this works, I'm just wondering about the potential of kind of wider scale education about food as medicine out there, for everybody, and particularly more at-risk populations, but for everybody, and other avenues like through I know insurance companies often do programs that are sort of preventative, that whole preventative medicine area that would be a great place to grow. Anyway, I just wondering if you have any thoughts on that.
Yeah, there's been a lot of sort of national efforts, I would say, in recent years. In 2022, the White House, so under the Biden administration, held the first in 50 years, so the first time in 50 years, White House conference on hunger and nutrition, and I'm probably butchering the order of the conference, but it was really designed to focus on sort of this intersection that we're talking about between hunger and health. And I think that is when there was sort of a greater focus or national focus at the very least on sort of these food as medicine programs and this intersection between food security and health and the ways that we can um, support interventions and programs in this area. And so since then, there's been sort of a lot of not just research, but also funding that's been put into place, as well as some national pilots. So from the Veterans Administration, as well as the Indian Health Services, that are looking to pilot these programs at a national level. As I mentioned a little bit earlier, there's also under what they're called 1115 waivers, which are demonstration waivers under Medicaid, to that allows for Medicaid to essentially pay under these waivers for these programs. So I think it's about 15 or 16 states that are currently have some sort of waiver. Don't quote me on that, but it's not every state, but there are a number of states that are have these waivers in place that allow them to pay for medically supportive food and nutrition services. And those are in various stages of implementation. And as I mentioned earlier, those waivers also have different languages in them. So for example, in Michigan, which is the most kind of recent waiver, I think, there's an emphasis on working with community-based organizations. In some states, there's an emphasis being put on uh, local sourcing. So, and then I would say also at the national level, I mentioned the GusU Macronutrition Incentive Program, GusNIP, which is a USDA funded program that supports produce prescriptions across the country. And there's a produce prescription in almost every state. Of course, there's many more that aren't funded by GusNIP as well, but there's a pretty broad reach of GusNIP funded nutrition incentive and produce prescription programs. And so I would say there has been growing momentum. And I think particularly like 10 years ago when people were starting to get really excited, for lack of a better word, of screening for food insecurity. And then all of a sudden they were like, oh, we've screened. Now what? We got to do something, which seems very like, of course. But then there was sort of this push of like, well, okay, now what? We should be really making sure we're not just identifying people. That doesn't feel great. We want to make sure we're actually connecting them to the resources they need.
Thank you.
Hi, just wanted to jump in really quick. I was wondering, perhaps your presentation covered this, maybe dive in a bit here, but was wondering about the implications of implementing food as medicine in public schools. So starting with young children and what benefits that could give us and the challenges that come with it as well.
Yeah, absolutely. There's a number of programs. Yep, and thank you. I did not cover that level of detail. There are a number of programs that work with schools. There's one program in Texas that called Brighter Bites. There's many others, but that specifically works with school health clinics. And it's a really, I think one of the important things to consider though is when you're, obviously we don't want to introduce stigma. Just want to make sure we're serving people in a, dignified and equitable way that doesn't sort of create disparities or create stigma for folks. I think that's true with any sort of program. But it's also a really great way to make sure you're feeding the family. So this is another sort of trade-off. Not every program feeds the whole family. We know that when you do give a program, likely the whole family is going to eat. So you might see if you're only sort of serving the participant and not the entire family, you might actually see reduced impacts because people share their food. They don't normally eat alone. And if you're serving children, it's helpful, I think, to be serving the whole family. But it's a really this is one of the things that, if you're meeting people before this is a good way to sort of have prevention efforts, I think. And there's been lots of good effects, I think, in pediatric populations. So there's been different studies in different pediatric populations of produce prescription programs on health impacts. But, I think it just depends on sort of what your ultimate goals are. But I think meeting people at school is a really good way to reach folks. And I'll also give one other example that, especially in rural populations where maybe there aren't health clinics, school might be the kind of meeting hub where that's where you are going to reach people better. It's not going to be clinics because mostly people are enrolled in clinics when they're getting care. Not everyone gets care, but not every place has a clinic either.
A follow-up question to that is how would you recommend in a scenario where this is implemented at a public school level, how do you recommend like tackling stigma?
Yeah, great question. I mean, I think you obviously want to make sure that you're not sort of making someone feel different when they're enrolling in the program. So maybe it's sort of like a categorical eligibility that everyone in the school is enrolled, or you're getting it as part of an appointment if there's a school-based health clinic. I think we want to make sure that we're not sort of like calling people out for, being enrolled in the program. But I also think that there's ways to do that by engaging people in the community. I think in general, any program, you want to be talking to the folks that you would be enrolling and making them part of the process. How do you want to, like, who do you think we should be serving? How would you like the program to be set up? Like, we can make guesses all day, but actually talking to folks who are going to be part of it, I think is really important. Yeah, Amber.
Mahima, I remember hearing that there are more and more just kind of partnerships with school districts
Mhm.
and the local small farmers to bring their products to the school for the school lunches. So I know that's happening in California, probably in many places. But one of the regenerative farms that we visited when I was doing climate farm school was participating in one of those. So beyond the actual food as medicine programs, this is just kind of school wide, which I thought was really, really, really great. I don't know that much about it, but I just thought I'd throw it out there.
Maybe I'll ask one thing to finish up, and then if anybody has any questions, feel free to jump in after. But I'm curious, for folks who are maybe new to the food as medicine, or are looking to get involved, like what are some good ways to engage with the food as medicine or prescribed programs? Yeah.
Yeah, good question. I think like looking in your communities wherever you are for if there's a food policy council that exists, that's a really good way to sort of like get engaged in the community, see kind of what other food work is going on. It's really going to depend on sort of your, region and your state. But if there are any sort of like coalitions in your region that are focused on food work, or CBOs, like food banks often tend to be really tapped into sort of if they're not doing food as medicine work themselves, sometimes they might not call it food as medicine work, but they are, or they're tapped into sort of the other players in this space. And so I would say sort of looking to see kind of what other community-based organizations, food banks, pantries, food policy councils, or coalitions are in your community and starting there. And that's a really good way to sort of get a lay of the land.
That's great. Thank you so much. And yeah, I think maybe we'll close it out there. Thank you so much for sharing everything and all your experience and knowledge with us today. And thank you everyone for such great questions. I thought this was such a wonderful discussion. So thank you for facilitating, Ronli. And yeah, I hope everyone has a great day. Thank you for joining us.
Thanks for having me, and feel free to email
Thank
me
you.
with any questions.
Yeah, that was a great talk. Thank you so much. Really informative.
Thanks.
Thank you.